I'm pleased to welcome everyone to the Academy session today, an AI solution driving patient impact and operational efficiency and ROI. Again, my name is Sydney Lupsey, and I serve as a research analyst on our member insights team here at the Academy. I'll set the stage for our conversation today and then turn it over to our panel for what promises to be a riveting discussion on all things AI, especially since AI solutions are gaining so much traction across the healthcare delivery system. So today we're going to talk about AI in the context of clinical care delivery, which we know has been on a lot of your minds for a while now. From our in-person meetings with the CMO forum and medical group executives to other conversations and headlines coming out almost daily, there's a growing sense of inevitability that AI is going to be a part of all aspects of our healthcare system as we move into the future. In fact, the Academy just conducted our priority survey to better understand what's on the top of all of you and your peers' minds. Interestingly enough, while AI varied across roles in terms of how much of a priority it is, almost universally, it was at the top of the list when it came to opportunity for improvement relative to where your systems are now. So clearly there's a lot of room for growth in this space, which is why we're really excited to have an AI expert and passionate proponent of AI capabilities with us today to hear about how his health system is integrating AI into their clinical care strategy, what they've been able to accomplish with AI tools to date, and where they think they're going next. So let's go ahead and get into it. I'm extremely pleased to announce our two speakers for today. First up, we have Jamie Strauss, the Chief Clinical Officer at VizAI. And joining her is someone I think many of you all know well, Dr. Eskioglu, the CMO at Novant Health. So Jamie, go ahead and take it away.
Hi, everyone. Thank you for being here this afternoon with us. We're excited to dive into AI and kind of do an overview of Viz and the impact it's had at Novant. So Viz was really founded with the purpose of bringing intelligence and integration to care coordination in order to really help the most vulnerable patients receive the care that they need in a timely manner. Viz was founded out of Stanford by our founder, Chris Mancy, who's a neurosurgeon, and David Galan, our CTO and co-founder. They were both doing some work at Stanford, and they identified an opportunity within ischemic stroke and started focusing on it. Viz's 4 pillars of our platform really focuses on alerts enhanced by AI, a high fidelity mobile image viewer, real-time patient information where we can capture what is clinically going on with that patient and communicate across multidisciplinary teams across large geographical areas. So Viz as an overview, again, we were founded in 2016. You can see that we are backed by some world-class investors. In 2018, we were awarded our first ever FDA indication for AI computer-aided triage. It was a de novo clearance. In 2020, we had another milestone that we received the first ever CMS approval for the NTAP, or the new technology add-on payment, which allows us to bring reimbursement to organizations where maybe they need to offset the cost of software, which has been been really equitable for health equity across areas. In 2021, we received a renewal for our CMS approval. And you can see we have a wide growing footprint across the United States and now growing globally. We cover about 100 million lives, 300 plus employees globally, and about 2,000 hospitals we're expected to be in by the end of 2023. So at Viz, one of our really core values is patients first, and we embed everything that into our technology, our software, and our mission with that. And our mission is to fundamentally improve how healthcare is delivered in the world through intelligent software that promises to reduce time to treatment, improve access to care, and increase speed of the diffusion of medical innovation. So when you think of Epic or Cerner as your system of record, you think of Viz as our system of action. And really where these two intersect is how healthcare is delivered. And that is what we're trying to strive to do at Viz. So how do we work? So we really are that system of action. So once a patient enters in, we start ingesting data from multiple modalities. Can come off of a DICOM, X-ray, PACS, EHR, any wearable data, and we're able to ingest that data into our infrastructure. It goes up to the cloud and is analyzed by our algorithms. where it detects, measures, and predicts disease. At that point is when we really trigger the action to the multidisciplinary care teams to receive notification if there's a suspected finding of disease. And the results that we've seen is impacted clinical care and clinical intelligence and optimized clinical trials. We use AI to really evaluate images and alert the relevant care team by any urgent pathology. So we started with stroke, but now looking into PE and aortic and other emergent disease states that require that urgent response from specialists. We process images in our secure cloud, and it takes about less than 3 minutes from completion. And then that alert is received. And through our analytics, we see that 93% of our alerts are viewed within 5 minutes of the intended specialist. So in stroke, we have a saying that time is brain. That's another one of our core values. And for every minute that a patient is experiencing stroke, 1.9 million neurons are lost. That's significant when you look at 123 minutes that we've been able to impact on average. That's the difference between you being able to go home or you having to go to a nursing home and really be able to care for yourself versus being cared for. And the reason we've been able to impact the time was because there was a lack of that care coordination across the space. We've seen significant time savings, so down from 123 minutes to procedure to 39 minutes in a number of institutions across the state. And intelligent care coordination works, we've seen significant improvements in patient outcomes, which has led us to the CMS NTAP. And I'm excited now to turn it over to Dr. Eric Eskioglu to talk to us about his impact he's seen at Novant.
Thank you so much, Jamie. And thank you, Sydney, for inviting me for this wonderful conversation. I'm Eric Eskioglu. I'm an Executive Vice President, Chief Medical and Scientific Officer at Novant Health. I am also a vascular neurosurgeon who has treated hundreds of patients in stroke. And this is actually personal for me too. My father died from a stroke 4 years ago. So I have professional and personal reasons to improve stroke care for all of our patients. At Novant Health, we are centered from the Carolinas. We're a multi-state organization with over 15 medical centers, of which 3 of them are tertiary, 2 of them are comprehensive stroke centers, and 1 of them is in the process of becoming a comprehensive stroke center. We do have a hub and spoke model. We have over 5.5 million patient visits every year. Next slide. So how do we measure the clinical impact to our patients? First of all, every AI project we choose at Novant, and I'm lucky to have my counterpart, our Chief Transformation and Digital Officer, Angela Yoakum. We actually are the co-executives of our Novant Health Institute of Innovation and Artificial Intelligence. So every project we choose clinically is centered around patient safety and quality. That's how we evaluate. Is it going to make a difference in the patient safety and quality? Once we figure that's going to have a big impact, we know the savings are going to come. And so in this project, particularly, we're looking at time savings. We had a pretty good door to needle time and also door to opening up the clot in the brain with thrombectomy time. Our door to needle times were about 39 minutes average in our system, but we wanted to get better. To Jamie's point, you lose about 32,000 brain cells every second of a stroke. Just imagine 32,000 brain cells. That is quite a bit. So time is more than, time is the utmost importance in this case. We also looked at how do we make it more effective and efficient? And again, going back to safety and quality, everything we do is centered on the clinical AI, on the safety and quality aspect. Next slide. So if you look at our traditional way we do it, and unfortunately, most of the institutions still do it this way. We were doing it at Novant about 3.5 years ago, the same way that you see in this graph here. So patient came in, had to go to the CAT scan, came back from the CAT scan, then you had to wait for the radiologist to read the image, and the radiologist will call to the front desk, get the ER desk clerk, and hopefully we'll be able to get a hold of the ER physician, and hopefully the ER physician will hang up the phone and have the clerk call the neurologist on call or the transfer center. And you get the picture. It's like tag, you're it. And it took a long time. It was very inefficient. And if there was one area that was stopping in the middle of this, or that was slow, it slowed down the entire process down. Next slide. So when you look at this, this is average in the country. So before patients get any treatment, if it's transferred from a spoke to a hub for major operation, it took 5.2 hours. It takes 5.2 hours. If it's within the center, it still takes 3.2 hours. And these are, when you put these hours in the context of 32,000 brain cells every second, you're losing millions and millions of brain cells, which really affects the patient's after recovery, and also in most cases can cause direct harm and death. Next slide. So what was, when we evaluated, and I'm proud to say that we were the first in the Eastern Seaboard to implement this about 3.5 years ago. When I came across this, we actually were using a different system, which we thought was fairly good, but we quickly realized that looking at this, that this system was going to be an amazing improvement to our current system that we had at the time. One of the things we looked at was it was not only going to increase the clinical output, but also increase the operational effectiveness. And to me, I can't stress how the operational effectiveness is really a bigger part of this as much as the clinical part. You know, most of our physicians here in our institution are millennial generation, and more so, they're becoming also Gen Z now. I'm dating myself, but they want everything on the on the convenience of their smartphones. So this system actually was easy to implement, and it made their workflow so much better, and it was really easy to scale. We have, as I spoke before, 3 hubs, and we have spokes. We have not only Novant Health spokes, but we also have Novant Health affiliated hospitals. They're not part of Novant Health, but wanted to get into our umbrella because they really like this solution. Next slide. It was interesting. Every AI project we start, it doesn't matter if it's Viz AI or any other company, we usually run a parallel track for at least 2 to 3 months. We want to make sure that our old processes are running and we don't abandon them immediately. And we run the current AI process to make sure that we build confidence in our clinicians. So this was the first Viz AI when we were implementing this and we were running our implementation. It actually caught a patient that had a large vessel occlusion in the right, it was actually the left middle cerebral artery. It was a big occlusion, and it caught it even before the radiologist catch it. The patient was immediately transferred to our tertiary center in Charlotte and had immediate surgery and went from an NI stroke scale of 26 to 0. And was, as a matter of fact, was discharged home within 4 days. And if this had been missed, it would have probably been a devastating outcome, even a death. So within the first day, our clinicians started really embracing this, and the 2-month period of parallel run became only 2 weeks because they want to immediately switch to Viz AI within 2 weeks, which was really satisfying and gratifying for me personally. Next. This is a sampling of our hospitals that were laggards in our system. I won't name them, but they were our laggards. What I mean is, on average, we had 39 minutes door to needle time, but these are the ones that were increasing our average times. And you can see how from 2018, when we first implemented, late 2018 to 2019 and 2020, and we have the 21 data that's coming in shortly, we have continuously improved this process. Currently, we are down on average to 29 minutes across our entire system. That's an average of 10-minute savings per patient, door to needle. That equates to about 19 million brain cells. Just think about the amount of brain cells we're talking about here. Next slide. So when you look at it, we can again show you our time savings. Our outcomes have improved tremendously. One of the things we're passionate about as an organization is health equity. Basic promise of democracy is equal and equitable access to healthcare. And if we can't provide that, you can't have economic upward mobility in the people we want to lift up in this country. So we're very passionate about creating equity in care. What Viz AI has allowed, and artificial intelligence continues to allow us to do, is it doesn't matter if the patient is in rural, Elkin, North Carolina, or Uptown Charlotte, North Carolina. They get the same teleneurology treatment layered with artificial intelligence on top. So the treatment modality is best of the best. The treatment process is best of the best, and we level the playing field. It doesn't matter which part of our system you enter into. The entry point to our system doesn't make any difference. You get the same outstanding treatment. Now, we're working on other disease states to do the same, but I'm proud to say that stroke, we have achieved that kind of unanimity and excellent outcomes. Next slide. One of the things from procedure volume is our volumes have gone up. Don't forget, not every patient that comes in is a stroke. There's a lot of stroke mimickers. We know this. They're also emergencies too, such as brain tumor that's starting to compress on our brain that may mimic a stroke. It could be a bleeding stroke. So not all strokes are the ones we treat using this AI right now. About 20% of them are ruptured strokes. And one of them that I have worked quite a bit in my career are ruptured aneurysms. It could be a seizure. It could be an MS exacerbation. But the nice thing is this AI is able to sort these out very quickly for us. And we're able to take care of more patients. Our umbrella for catching any kind of brain emergency disorder using this AI has grown tremendously. When you look at it, because of these cases being done, because we're saving lives, our revenue has increased about $1.8 million. And from the cost of reduction from the AOLS, we're down about, we saved 1.7. So you can look at overall about $3.5 million savings, which really, in this case, our margin brings mission. We're a not-for-profit organization, and we need to afford these incredible technologies, but we need to have the margin to be able to do that. Next slide. One of the things that we're proud of is that we actually were one of the institutions that really lobbied heavily the Labor Committee at Senate, including Senator Burr, which I have written personal letters, because again, my personal experience from my father, and we wanted our rural hospitals and our own hospitals to get paid when they ran a Viz.AI algorithm. So we're proud to say that this was the first, and I'm telling you, not the last. So this is the very first algorithm that the FDA approved for payment. It's very similar to those of my hospital administrator colleagues. It's very similar to the technical fees we get for doing operations and surgeries in the hospital. So Medicare will reimburse us up to $1,040 per patient that has a Viz.AI algorithm that runs through their imaging. Now, the good news is also the final diagnosis does not have to be stroke. It is accepted for diagnosis of suspected stroke, initial diagnosis. Even if the final diagnosis is brain tumor or something else, we still get paid for that. And this has been an incredible addition. Next slide.
Thanks, Eric, for your overview. Appreciate it.
Yeah.
For Viz, we really started as that mobile platform that Eric highlighted, really because of the ease of use and access, not needing to be tied to any workstation. But as we've grown and evolved in making sure that we include everyone into the workflow, we focus on bringing everybody together. And we are a proven platform, and that's been done through the validation of CMS and some of the clinical studies that we've done, and bringing that best-in-class pre-pack solution across a mobile platform as well as a desktop platform where we're integrated into the packs and they're able to view all and have the same functions and features of communication and alerting on the desktop platform. And we work really hard to embed into the care team's workflow. So looking back at the sequential process of stroke workflow and how we've been able to embed and shrink that time to have time savings and better outcomes. So we are an AI-powered care coordination, really started in that stroke space, but now evolving to broaden out in the neurovascular with intracranial hemorrhage, aneurysm, subdural hematoma, cryptogenic stroke, and moving beyond outside of neuro, where we can continue to make impact in other urgent emergent diseases like pulmonary embolism and all of aortic disease. So type A dissection, type B dissection, AAA, endoleak management, and rupture. We're also focusing on trauma, spine, orthopedics, and cardiovascular to round out our platform, so we're an all-in-one offering. Another thing we're passionate about is moving science forward. So this is, we're really involved in making sure that we have applications available for clinical research studies and really want to be part of better outcomes for patients. And the way that we do that is through the clinical research. So Viz Recruit allows us to identify patients for suspected pathology that then would be eligible for enrollment into clinical trials. And I think, Eric, I'm sure at your organization, you're running a number of clinical trials at one time. And it's hard to remember which patients are eligible for which study, and really being able to automate that process. And especially in the world of COVID, where we had staffing constraints and research maybe was slowed, we're able to add value for that. We really focus on clinical programs here at Viz. So partnering with, Dr. Eskioglu and other partners across the country to bring meaningful work through different types of studies, industry partnership studies, investigator-initiated studies, any applied research projects, and really working as a clinical team to move science forward. I'll stop there. Sydney, turn it over to you.
Yeah, great. Thank you, Jamie and Dr. Eskioglu. That's a really helpful overview. If anyone has questions, please feel free to continue sending them into the chat. I've had a couple come in, so happy to tee them up now. I think your expertise and perspective would be great to address them. So I'm curious, one chat came in that says, it sounds like the Novant clinicians are really bought into the AI solutions that you've implemented, but they're a little curious if you faced any specific implementation barriers.
Yeah, so again, the way we approach it is from the safety and quality angle, and everybody, including our CFO, our COO, everybody will agree to that. So we're all working for that mission. Then we find physician champions clinically. It can't be one person pushing this. So we want to make sure that there's physician champions. In this case, we had multiple champions. We had our chief of our neurosurgery group, Dr. Eric Deshay. We had our stroke neurologist, neurointensivist, and neuroradiologist. And so that does make a difference. We didn't, to be honest with you, from the time we decided to put this to the implementation time was less than 3 months. And that's, again, credit to our digital product services group, our chief executive for our transformation and digital. And, so what I recommend is make sure that you're working hand in hand with your data scientist and your digital products group, because that's what makes it really special here at Novant. We have such a good relationship. We really work in hand. And us clinicians, we actually pose the questions. And when we come up with possible solutions, they're at the table vetting it with us, because they want to make sure that, when we met with Viz AI, we had our, executive vice president, chief transformation digital officer. We had our chief data officer. We had our CIO. They're at the table with us, making sure that what we proposed to do was easily implementable. And so those are things I recommend.
Okay, yeah, that's great. I'm curious, Jamie, from your side of it, is there any recommendations from the industry perspective on implementation strategies and how to avoid those barriers?
Yeah, I think, it's really understanding the structure of the organization. And prior to this role here, I was hospital executive, so familiar with both sides of the world. And it's making sure you have a strategy from your organization level of what does that process look like. And from our standpoint at Viz, we really work to partner with our sites to help streamline that implementation. We're a cloud-based solution, so there really isn't a huge pull on resources from the IT side. And that's really always a conversation that we like to go to the table with. It's cloud-based, it's virtual servers. We're able to connect and stream in. We don't even have to go on site. So the easier that we can make it as an organization to streamline implementation and get the technology in the hands of clinicians to better improve patient outcomes is always our focus.
Yeah, and Sydney, Jamie brings up a good point. One of the things we did, we're one of the first, we're an Epic shop. I'm sure a lot of our viewers are either Epic, Cerner, or there are other smaller ones. But we moved our data to Microsoft Azure Cloud, because when you're getting to AI, you really can't depend on servers. You need petabytes and petabytes of memory. And this has made it easy for us to be able to select a company, or we sometimes do things on our own. We have a cognitive AI group with data scientists and PhDs in data scientists. So some of the projects we do on our own, but unless you have moved your server, your data to cloud, I think it'll be very difficult. And we've had a great partnership with Microsoft. You know, they've been really good working with us. And I think those are things that, it doesn't matter. It could be Microsoft or AWS, I think. But, you know, that's been a great partnership for us.
Yeah, that's really helpful. And I think that kind of tees up my next question, which is, what do you look for in a partnership when you're considering implementing AI solutions, and vice versa to you, Jamie? You know, how does your AI solution best match up to the leading health system that you're partnering with? But I'll kick it over to Dr. Eskioglu first.
Yeah, well, first of all, you know, I was an engineer before. I was an aerospace engineer, so I'm very data science oriented and really love what we're doing. I actually look to see, did they train their data on heterogeneous populations? That's the first important thing, because I want to make sure that the data is not trained, the algorithm is not trained on populations that doesn't represent our community. So that's the first important thing. Then I ask about false positives, because that's an important thing. If their false positives are high, that is a flag to us. And then the next thing is, again, the biggest thing for me is this going to improve the safety and quality of our organization? Is this going to make a difference in our patients' outcomes? You know, we pride ourselves in giving remarkable patient care. And in order to do that, you have to reduce the safety and quality incidents, you know, anything that affects that. So those are the specifics we look for a company. And we're not looking for solutions to, you know, pinpoint one solution, what I call one-trick pony. We want to grow with the company as they come along with us. So if we believe in the product they're doing, and we know they have bandwidth to hopefully take on other products, we want to help them grow, but we want to grow with them. So those are, you know, technical and clinical considerations we have.
Yeah, and from our standpoint at Viz, you know, we really work closely with our sites. So we have a customer success team that spends a lot of time with customers on the ground and observe the workflow, and not just in stroke or in PE or aortic or the disease states that we're focused on, but even beyond that. And, you know, oftentimes the clinicians are like, if I had this AI that would make this impact, it would make my life so much better and be so much better for patients. So we work closely with them. And then when we take that, we have a great AI team, very robust physicians on there, some of the most thoughtful AI leaders. And when we're building a technology, to Eric's point, we don't want to over alert physicians. We don't want them to contribute to burnout. It's so critical right now with the state of healthcare. And we want to make sure that we give them a product that is truly alerting them on something that is with high sensitivity, specificity, and low false positives. We do tons of clinical validation studies in the background during that process to make sure that when we give them a product, it is going to be the best product possible for their care.
Yeah, I definitely have a follow-up question on that because you brought up a really good point. But first, I want to make sure we cover the one most recently in the chat. This is for Dr. Eskioglu. It says, in regard to the FDA approval for reimbursement and coding, is using the AI adds a procedure code that affects the DRG, or is it a code that gets reimbursement added to the DRG payment?
No, it's separate. And what is really nice about it is it's really helped our rural hospitals. You know, we want to support the non-Novant, but rural hospitals that are critical access in North Carolina and Virginia and other areas we serve. And what this has helped is, if the algorithm is run, if the patient is in that hospital, that rural hospital gets that payment. It's not Novant getting that payment. And this helped them financially, because now we can provide those services and hopefully keep most of those patients there. But then we get that add-on payment of $1,040 for Medicare. Now, private insurance has been a little bit slower to catch on, but we're working on that, getting the third-party payers to also approve this as well.
Okay, thank you for addressing that. And another question just came in. I think this can go to both of you guys. So maybe we'll start with Jamie, but to what extent has AI extended to the patient home with wearables or RPM passive devices to reduce the amount of symptom occurrence in emergency departments or the ambulatory space? Are you guys in this space? Where are you thinking next here?
Yeah, so for our standpoint, again, we look at any of those critical kind of diseases and problems that we want to solve. So if there is data coming off the wearable, we're able to ingest it and build an algorithm off of it to impact that patient journey. So we really look to solve those complex problems. We're branching out into cardiovascular. We know a lot of patients leave hospital, come in, chest pain, go home with either a Holter monitor or wearable or a patch now, and we're working to integrate to ingest that data. So we're able to provide meaningful analytics and machine learning to that.
Great.
Yeah, and I would add, I'll talk a little bit more philosophically about this. So as you know, our medical knowledge is doubling every 72 days. And in the next 3 years, it's expected to double every 30 days. There's just no way a human mind is going to be able to keep up with that veracity and big amount of data. I look at AI as, our pilots. I always go back to the aviation industry because that's where I cut my teeth. And when you look at the safety record of the aviation industry, it's because they not only learned from each other's mistakes, which we are not doing it currently in the health systems. And the example is, unfortunately, if it was a Delta airline that crashed many years ago, every airline found out what the crash reason was and how to fix it immediately. We don't have that in healthcare. If something happens in my institution, my counterparts across the street have no idea what happened and how we fixed it. So I think AI is going to hopefully open those doors for us. The other one is, I give the example of pilots. If you were to go to the airport today and getting ready to board, and if the person at the desk calls and says, our flight's ready, our co-captain and captain are ready, our autopilot's disabled and we'll be flying without the autopilot. I would tell you, me and probably 50% of the people will walk away and say, we'll come back when the autopilot's ready. And we need that in healthcare. The physician and the nurses, and let's not forget about the nurses. The physician and the nurses need this extra sensory input, what I call ambient intelligence, and that goes to the wearables, that can be digested and give important clues what may be happening to the patient and not get alarm fatigue. I also look at AI as helping our physicians and nurses with burnout. Again, Jamie mentioned this briefly. We're hoping to reduce the alarm fatigue because we want them to be alerted only for things that really, really matter, not things that don't make a difference in their workflow. So those are things. And one last thing I would say in this subject is, people are always worried, is AI going to replace me? I get that question a lot. Is Dr. AI going to see patients in the next 5 years? And my answer is absolutely not. But I can tell you with 100% certainty that physicians who use AI are going to be so effective and have more time to spend with the patients are definitely going to replace physicians who resist AI, and nurses too, same thing.
Yeah, absolutely. I also think I hear that a lot from our industry members, is that it's all about the messaging with AI. You guys, AI is not replacing the workforce, it is augmenting it, and it's improving it and helping it, which I think, Jamie, you got that point across really well. A couple other questions. One is, for leading health systems that are early into adopting AI, do you have any recommendations for deploying AI in terms of governance structure? And I'm curious, once you have a governance structure embedded, how do you scale it? How do you embed that further into the organization?
Yeah, I can take that. So we do have in our Institute of Innovation and Artificial Intelligence, both Angela and I have other counterparts in there that are the core team that makes these decisions. And we get AI, suggestions from everybody. So it doesn't matter. It could be a nurse, it could be a physician, and we evaluate them based on the criteria we talked about, looking at the safety and quality and how much investment we need to make and what's the runway. And we also, look, not every AI project we've done has been 100% success. We have had a couple of hits and misses here. And we look at it as fail fast. We learn from those experiences and we apply to the next one. I would say a good percentage of our projects have been very, very successful, and we vet them out very thoroughly. But again, I would put that structure in place and cultivate that you become a repository for AI projects. People want to come to you, and then you evaluate them with them, and they can come and present to your, to your team that is evaluating this.
Mm-hmm. Yes, absolutely. And we had another question come in related to workflows. So this one is for Jamie. For those health systems with radiology residents providing a preliminary radiology read, how does Viz.ai fit into that workflow?
Yep, thanks for that one. So from a workflow perspective, when we go through an implementation process, we have an implementation team, we have a customer success team, and a clinical workflow team. And they really work to understand how your current process is mapped, and we provide workflow maps. And then we work with the sites to see where the optimization is. So a lot of times, it varies across organization of how they use Viz in their platform, or in their workflow. But I would say one of the best ways I've seen it is when the radiologist is actively engaged, or the resident, they provide the wet read. So off of the original scan, apply give the wet read in the application in the chat, and then they can move that patient, continue through the imaging workflow. There's also a component of the technology that you can see when an image was done, when the read was done. And because the EHR can be cumbersome to mine data, sometimes we've seen a lot of organizations take the analytics on the back end from Viz for their QTI. And when they have their quality committees and they're focusing on radiology read within 10 minutes of a completion of a stroke CTA. And we've seen that help them track their data and mine their data.
That's helpful.
And back to that one more thing, Sydney, sorry. So the cloud-based solution allows that configuration of users and user groups, and how we configure them to customize that across any organization, large, small, standalone, large health systems.
Okay, great. Thank you for addressing that. I have one more question in the chat. Doing a final call for questions here, please send them in as we do have a little bit more time. But I'm curious, and this is more, the plan for the future. Where do you guys see AI going in the next 5 years or so? Especially, I know Dr. Eskioglu, we did chat about the ethics of AI, especially around clinical care. And I'm interested how that plays out in the future as well. Would love your take from both of you guys.
Yeah, I can go first on this one. So obviously, I see AI becoming bigger and bigger part of our daily lives. It's already in our daily lives. I mean, when you look at you're driving your car, you got ambient intelligence. Tesla cars have over 150 sensors all around it that gives you input that you make the decision. So we have AI in many different areas of our lives. And healthcare is a little bit behind, but we're catching up. So I see it entering into our lives in healthcare in a big way. I think it's going to help with physician and nursing burnout for sure. And we don't have enough physicians also. If you think about it, during the pandemic, we have lost nurses and physicians, and I don't think they're coming back. So the workforce is a big issue. So we want to extend the workforce life and make sure that we bring the joy of taking care of patients back. The one part of AI, and look, I'm a big AI evangelist. I think AI is going to be great for us, safety and quality. I can see our safety and quality record with AI becoming what the aviation industry accomplished over 20 years. I can see us getting there in the next 5 years. One area that I would caution is what I call the dark side of AI. And the dark side of AI is, unfortunately, our technology moves a little bit faster than our social norms. And in the next 5 years, I can really, with a good certainty, say that we are going to be able to predict what the chance of survival of a patient is given the condition they have. For example, I can tell you, if it's a 92-year-old lady who's mildly demented, has congestive heart failure, atrial fibrillation on Coumadin, blood thinner, and falls and breaks her hip, I know we're going to have algorithms that's going to be able to ingest all her data and be able to tell us what is the chance of her survival from that hip surgery. And my biggest concern is the insurance companies and the government putting the physicians and nurses in front of this and telling us if the chance of survival is less than 25%, you cannot operate on that patient. And I don't want to be the bearer of bad news. I don't want to be that person that doesn't want to do that, because as physicians, we want to be able to save everybody. We work really hard. And so I think that's the part that we have to decide, and how, and, as hospital administrators, hospital executives, as physician leaders, as physicians, we have a moral obligation to come up with, these rules and regulations before it is put on us. And right. Obviously this is an early stage, but I would urge everybody on this call to start thinking about, how can we control this, and how can we come with a better, better result for our patients?
Yeah, absolutely. A lot to take away there. And Jamie, I'll punt the question to you. Where do you see, where's Viz AI going next with AI?
Yeah, I think we're really looking to solve any complex problems that lead to better patient outcomes, right? Like, so again, we focus all on patients first, but also back to Eric's point of workforce. So, I'm a nurse by training, and there's massive nursing shortages, massive nursing turnover with now nurses traveling. So you lose that consistency in process for patient care, right? And what the expectations are between each organization and how we care for patients. So I think any AI that can come in and help to support the workforce right now is so valuable. And then really, what problems do we need to solve for patients so they have better outcomes? And that's really everything that we look at from the beginning when we're making decisions around AI. We showed you a little bit of our kind of roadmap, and now looking at trauma and oncology and spine, and moving down towards, other disease processes that's scalable.
Mm-hmm. Absolutely. And my final call for questions was a hit. We have a few more. So one that I think is interesting, this is probably for Dr. Eskioglu, as you talked about door-to-needle times, but can you estimate how much of the improvement in door-to-needle times was the AI support read of the images versus fine-tuning of the multiple steps involved?
Yeah, so I think I'll rephrase that question.
Mm-hmm.
What portion of it is due to clinical diagnosis so quickly and making that difference, and what portion is due to clinical operations improvement? And I would say it's about 50-50. Really, it's about 50-50. That's why we love working with a company like Viz AI, because they not only brought clinical solutions, which we desperately needed, quick clinical solutions diagnosis, but it really improved the operational efficiency. And so I would say in our case, it's a 50-50. Now, if you look at our hubs, we have fantastic neuroradiologists, they're fellowship trained. So the Viz AI doesn't make as big of a difference. But when you look at our spokes, where we don't even have radiologists in-house at nighttime, let alone neuroradiologists, it made a huge difference, because the diagnosis is so much faster and so much easier and so much accurate. So it made a big difference. So I would say 50-50 at this point.
Can I chime in there just to, I was a Viz customer to my centers before, and we thought we were like really good, with our door to needle and our door to groin and door to rear perfusion times. I think what we saw when we implemented it was you now had this ability, you weren't waiting for the stroke nurse to call the radiologist and the neuroradiologist to get the read, and then the read to get to the neurologist, and then to get to the neurointerventionalist. Everybody was receiving that information at one time and able to coordinate the care. And that is why we focus so much on that workflow and intelligent care coordination, because when you can pull the whole complex care team together and make decisions in less than 2 minutes, it has a significant impact on the operational efficiencies that Eric kind of speaks to.
Yeah, absolutely. I appreciate that perspective. And I have another question. This is for Dr. Eskioglu. Where do you see new data sources for AI moving beyond imaging, moving into prevention or chronic diseases? Do we need more wearables, genetics, or even diagnostics?
Yeah, this is a terrific question. I applaud the person that's asking, because I think they're really visionary in this question. Yeah, I actually, everybody is surprised. I'm probably one of the most highly subspecialized physicians you can find, a vascular neurosurgeon who's done a neuroendovascular fellowship. But I think the biggest effect of AI is going to be primary care. And people get surprised when I say that. And the reason I'm saying is, first of all, primary care physicians are constantly in touch with their patients, right? They have the constant touch points. So it's not a one time or twice. They accumulate a lot of data. and they really do need the help of AI. And what I can tell you is everyone that's on this Zoom today, I'd want you to, when you go back to your primary care physician, nonchalantly, next time, ask them, how many notes do you go back when you look at my care? How many labs do you go back? How many images do you go back? And I can guarantee you, I practice, and it's usually no more than 1 or 2 notes and maybe 1 or 2 images. And hopefully my note from the before captured the essence of the note from the before. And the problem with that is you're missing patterns. So AI is going to be able to come in and hopefully in the next 2 to 3 years, and maybe even sooner, be able to get the patterns looking at the patient's labs, looking at the patient's imaging. It may be completely normal. You don't have to worry about it, but it may say, hey, look, this patient's hematocrit, which is what we measure for blood, is ever so slowly going down and may be at risk of having possible colon cancer. And so you can't see that with one snapshot, but you can definitely see that with a trend. So I think that's where it's going to make the biggest impact. One other point, I'd be amiss if I didn't say that, because I got a lot of questions about, how do you get AI to be accepted in your institution? First of all, obviously, we talked about the physicians and champions and, my co-executive, Angela Yoakum. But one of the biggest things is our chairman of the board and our CEO have bought into this. They are big believers. And if you don't have the support of your board and your CEO, it's really hard to do that. And, again, our CEO, Carl Armato, is very visionary. He saw this when we started talking about it 4 years ago, and he really put his weight behind this. And if you have that kind of support, it's really easy to, I shouldn't say easy, I'm making it sound easy, but it removes barriers. And, I can tell you, because we used a lot of AI in different areas, we use it in safety and quality, predicting sepsis. We're using it in heart failure readmissions. And because we use these digital tools, we're probably one of the few institutions during the pandemic, we have driven down our hospital-acquired infections by 30%, and our serious safety events by 40%. I can't tell you that there's a lot of institutions that can say that. And that's testament to the fact that we not only use AI, but we've put in place processes that are almost, put in steel. It doesn't matter if a traveler nurse comes in or a physician that's a locums comes in. The processes are so well put together that's hard to break those processes.
Yeah, those are some really impactful numbers. Absolutely. Okay, so this one is for Jamie. It's on clinical trial applications. Is the Viz AI opportunity to identify patients, or does the speed create a situation that is faster? And apologies, I'm not sure what SOC stands for, but faster versus SOC.
Standard of care.
Oh, thank you.
So both. So the way that we work on the Viz Recruit side is we can take any ingestion of data and augment it for like inclusion exclusion criteria for a specific trial or identification of patients for clinical studies. So we look, like if you look at the standard of care, it's typically somebody knowing or mining the chart to find the patients with the right diagnosis code, or in the emergent setting, with our acute stroke trials and our acute hemorrhagic stroke trials and aneurysms, you have to find that patient at that point of entry. And you hope that the PI you hope that whoever is detecting the patient, the PI is on call that night. Otherwise, those patients may get missed. So it's identifying those patients, and then it's also speeding them to be eligible and screened for the inclusion exclusion criteria, and if they meet or don't meet that criteria, to get into that study.
Yeah, thank you for that. I have one more question here, specifically about workforce, which of course is on the top of many of our minds. Could Dr. Eskioglu, could you explain a little bit more about how you're thinking with regards to AI, how you're thinking about retraining the workforce, or what type of new skills the workforce might need to successfully adopt and leverage these AI solutions?
Yeah, absolutely. Well, first of all, I'll start going into the medical school. So a lot of medical schools are now starting to adopt AI curriculums. I am fortunate enough to work with Dr. Anthony Cenk, who is the head of the American Board of Artificial Intelligence in Medicine. And we are working and implementing this at least in 8 academic medical centers in the medical school curricula. Now, that doesn't mean that they're all going to be MD, PhD data scientists and clinicians, but I think the future of healthcare is going to depend on those people. It may be a handful, maybe 10% of the medical school class that gets an MD, PhD in data science, but I see that moving forward happening. The exposure of the medical students just to understand the AI aspect is really important. They don't have, and I give the example of microwave, right? We all use our microwaves, we trust it, but I would say 99% of the population doesn't know how the microwave works, but we trust it. And I think we need to get to that point with medical students. You know, they need to get to that point. They understand, but they don't need to do like, you know, I can do Fortran, Cobalt, and Python programming. They don't need to do all of that. They just need to understand how it works and how to get the questions. So I think that's where it's going to start. As far as our physicians, you're never too old to get into AI. I mean, I hear this from a lot of physicians in their 50s and 60s. Oh, that's new stuff. I will never be able to learn that. Look, you're a physician or you're a nurse. You're brilliant. You're the top of the population already. You're so smart that you should be able to get this. And it's just that, to me, if you're an organization that's thinking about going to AI, I'd pick as something that's really easy to understand for people to understand. You can message it really easy to your C-suite, non-physician partners. And also you can see results pretty quickly. And I think in that sense, Viz AI was really easy for us. Now, we do work in another area of radiology with another company where they actually stratify the patient lists. You know, the patients in most of the ER radiology queues come in and it's time stamped. Everything in ER is stat. So you can't distinguish which is what. And when it's time stamped, they can have 48 images in there that are looking great and they have nothing abnormal. And the 49th could be that ticking time bomb with a brain bleed they haven't gotten to yet. When we implemented this, the first thing I heard from our radiologists is this has really released the anxiety from us, because we always wonder, is there some ticking time bomb in that list that we haven't gotten to? And that actually gives you a little bit more job satisfaction and definitely helps you with the burnout.
Yeah, I very much agree and appreciate your perspective there. I think we're getting ready to wrap up, and I do want to say if anyone has questions after the fact, we can absolutely address them beyond this presentation. But I wanted to give you guys both the chance if you had any closing thoughts or want to something to end us with. I wanted to go ahead and provide that now. This conversation has been extremely robust, so I really appreciate this perspectives from both you guys.
Jamie, you want to go first or you want me to go first?
So you go first. We'll probably say something similar. So
okay. Well, again, I first of all applaud everybody for being on this Zoom because it does show me that there's a huge interest in AI, and it is here to stay. As far as the original really success in AI have been in radiology, we're also seeing it come in excuse me, in pathology as well. So pathology is an area, and so it's going to be interesting. But we're also looking beyond that. I see a question about, do you use natural language processing or do you use abstraction from coding? And we do both. So I think the AI is going to develop in a way that the groundswell from the radiology and pathology, we're also going to have this natural language processing that comes in. And on top, we're going to have what I call the ambient data. That's like my new thing. I'm really fascinated by the data that affects the surrounding data that affects the patient, not the patient's data that comes out of the patient, but the environment. So I think that's going to be huge for us. And look, the technology companies are all looking around, they are getting in. I mean, I used to say 2 years ago, they're just dipping their toes. Microsoft bought Nuance, which is the biggest natural language processing. We use that for our dictations. Oracle just bought Cerner, which I never thought Oracle would get into healthcare. And healthcare is a quarter of our GDP. So they are looking at that as a growth area, next growth area. So get used to having technology companies collaborating with you. And if we don't evolve as healthcare systems, my good friend, Dr. Amy from Providence, she says, we're going to be like, we're going to end up being subsidized utility companies, healthcare systems. So we need to evolve. Amy Compton Phillips, she's brilliant. She says this. And so we need to evolve. And to evolve is really, partnering with technology partners and really finding solutions ourselves. So that's where I would end my conversation. Really appreciate the time. Really appreciate Jamie partnering with me. She's phenomenal. So thank you so much.
The pleasure's all mine. Just to add on to that, I think that, you know, really embracing AI and where we're going with it, and, you know, being on now both sides and seeing how it does impact patient outcomes and care and workflow efficiency and operation, and actually has a huge ROI for organizations. I mean, I think it's exploring it and having those conversations and finding really good partners that partner with you and are invested in your program and want to help you elevate your program and organization and institution. You know, we work really closely and have that clinical partner program where we work together to solve some of these challenging problems and complex problems to bring solutions. So I think it's embrace it, push the boundaries if your organization doesn't adapt to it, but think about how do you push people to get comfortable with it? Because I do think it's here to stay, and I think it's better for our all of us, really, because at some point we're all patients, right? So it helps all of us.
Yeah,
and
a really good
for the time today. It's been great.
Oh, of course. And a really great ending point. Yes, at some point we are all patients. I really appreciate that. Thank you guys. Thank you both for joining us and sharing your thoughts and expertise. Your perspectives on this are really valuable. In closing, we will send the recording and slides and follow up. Again, please don't hesitate to reach out if you have any questions. And in terms of closing notes, our in-person Academy Spring Meetings series will kick off in about a month or two. So we really do look forward to seeing a lot of you guys in person.